Thank you for giving me the opportunity to present this case this morning. So this is a 68-year-old gentleman who was seen in clinic with us, and he was essentially asymptomatic and was seeing his primary care doctor for a routine well visit, essentially, and his primary care doctor felt a large abdominal mass during this routine evaluation. So he naturally followed up with the patient about this. And the patient at this time really had no symptoms whatsoever. He had noted some mild postprandial heartburn, but he had noted that he had had heartburn intermittently throughout his life, so he didn't feel that this was particularly unusual. But this was his only symptom. He had no other constitutional symptoms. He had no fevers, chills, night sweats. He had no weight loss. And his review of symptoms was otherwise essentially unremarkable. As you see here, his past medical history was fairly non-contributory. He had really had no surgeries other than a tonsillectomy. He had no significant family history of any cancers. And he actually is employed as a physicist, but had no other significant social history of note. On physical exam, his vital signs were fairly unremarkable. He was a very well-appearing middle-aged gentleman, and the only notable thing on his physical exam was that he had a fairly easily palpable abdominal mass that was extending to the pelvic brim. He had some initial routine workup, including blood work that showed essentially a normal CBC, and his LDH was not elevated at presentation. So he had a staging PET CT, which revealed a large right paramedian retroperitoneal mass encasing and slightly displacing the aorta that you can, don't worry about it, that you can see here and here, of course. It was 9.6 by 5.3 centimeters in greatest dimension, and it had marked hypermetabolism with an SUV of 20.2. And he ultimately had a core biopsy of that mass that showed an ill-defined/diffuse proliferation of small to medium-sized lymphoid cells, resembling centrocytes and a few admixed larger forms consistent with centroblasts. There were less than 15 centroblasts per high-power field. It was noted that the neoplastic cells were positive for CD10, BCL2, and BCL6. They did not express the T-cell marker CD3, and the Ki67 proliferation index was low, and the ultimate diagnosis was follicular lymphoma grade 1-2, and his initial Ann Arbor stage was stage 2A. Oh, I guess I skipped ahead, but I guess we can save, since this is like a genomic discussion, for later, and we can just go through his treatment history. So this was his initial presentation, stage 2A follicular lymphoma that was grade 1-2, and as you all know, there are a number of treatment options that can be pursued in the front line for follicular lymphoma. However, there was significant concern for de novo transformation at diagnosis because of the marked SUV uptake that is somewhat out of character for follicular lymphoma with an SUV of 20.2, and his diagnosis was only made with a small retroperitoneal core biopsy. And essentially the feeling of his oncologist at the time was that even if you did another core biopsy that showed follicular lymphoma, there would still be concern for some areas of de novo transformation. And so since R-CHOP is a fully reasonable therapy for both follicular lymphoma and de novo transformed diffuse large B-cell lymphoma, he received 6 cycles of R-CHOP, which he tolerated quite well. Unfortunately, his end of treatment PET showed essentially stable disease. There was a slight reduction in the size of his mass, but the SUV was around 14.8 at this time. So this was essentially stable disease to frontline therapy, and he was considered to be a primary refractory patient. Given this fact, he was treated with consolidative therapy with radioimmunotherapy, ibrutinib, tiotexin, or Zevalin. And a follow-up PET scan after this treatment showed a fairly significant partial response with significant shrinkage of his lesion and a decrease in the PET avidity of the mass, and he was subsequently observed. He had some thrombocytopenia, but he was otherwise recovering well. He was actually recently seen in clinic, and a repeat PET scan showed that his, unsurprisingly, since he did not achieve a complete response to his consolidative therapy, that his mass is slowly growing and gradually increasing in SUV avidity. So this is the point at which we were kind of thinking about what would be the next step for him with his relapsed follicular lymphoma after a couple of lines of therapy. And this was the point at which his tumor was sent for Foundation One Heme sequencing, and that revealed a number of mutations that would be fairly classical for follicular lymphoma, but I'm just noting these two mutations, both of which actually Dr. Intelkofer helpfully mentioned. One is a hotspot monoallelic mutation in EZH2, a mutation of the tyrosine 646, and then the other one that I'm highlighting is the TNFR SF14 mutation, which is an inactivating frameshift mutation. There was also the classical IgH BCL2 rearrangement, a mutation in BCL7A, which is a chromatin modifying gene that is commonly mutated in follicular lymphoma, and a mutation in MLL2, which is a histone methyltransferase that Dr. Intelkofer also mentioned that's very commonly mutated in follicular lymphoma. So I guess if now the panel wanted to discuss how they might utilize this information.
So I think, is there anything, insight that you glean from that information in terms of the concern for more aggressive biology or therapeutic information?
I guess from the pathology perspective, at least it confirms that it was a follicular lymphoma. We have the BCL2 translocation as typical mutations, but we don't see any of the high-risk mutations associated with transformation. Of course, your sample is your initial diagnostic sample.
Yes.
So you have the risk of still, as you had, SUV and the morphology does not fit, and the mutation and the SUV does not also fit. So there may be some more aggressive disease, but I guess you'll tell us what happened next. But that's yeah. And from the treatment perspective, you guys know.
Well, he had another biopsy also.
Okay, so that was still low grade.
After the treatment, which showed basically
Same thing, yeah.
Now everyone knows his treating oncologist, I guess.
I'm old enough to know. Only old people in the room would actually give that one. So but this is the imaging was just the other day.
Yeah. So, I mean, I think this is just a quick opportunity. He actually hasn't received any subsequent therapy, but we have discussed what we might give him next. And I think Dr. Intelkofer already covered this, but I'll just quickly say that EZH2 inhibition is sort of a great story, both from the MSKCC perspective and collaboration between institutions that are at 68th and York. So a lot of the seminal work characterizing how EZH2 mutations promote lymphomagenesis was done between Ari Melnick's lab at Cornell and collaborating with Ross Levine and Omar Abdelwahab's lab here. And they essentially showed that this EZH2 is a member of this PRC2 complex that deposits these repressive methylation marks at H3K27. And what that does is it blocks expression of lineage-specific genes, thereby blocking germinal center B cells from differentiating into either memory B cells or plasma cells. And they were able to show in some of this seminal work that when you give these mutant cells an EZH2 inhibitor, they become morphologically differentiated into plasma cells, and they induce expression of lineage-specific genes like CD138. And a parallel study that came out in Nature that year showed that in particular EZH2 mutant cells were particularly susceptible to that inhibitor, and you could give mice that had been given this lymphoma the drug, and they would survive essentially. And that moved into a phase 1 trial of the EZH2 inhibitor, and in that phase 1 trial they were able to see responses, as Dr. Intelkofer mentioned, in both EZH2 wild type and mutant lymphomas. This is just an example of a mutant follicular lymphoma that had a partial response to therapy, and so therefore it's moved into a phase 2 trial being led by Dr. Jaracitano, and I think it's, as Dr. Intelkofer mentioned, this is a really important part of us both learning from and expanding on the biology that we see in the lab, because there are responses that are being seen out of what we would have predicted biologically, and so accordingly the phase 2 trial is enrolling patients across multiple different cohorts that includes both patients that have the mutation and don't have the mutation, and this is going to be an opportunity for us to take the bedside information that we get and translate it into more biological knowledge. So thanks, guys.
Thank you.
So I just want to have an opportunity to discuss with you a couple of clinical cases where we've used this genomic profiling information to manage our patients in the clinic. So just a quick preview. So primarily in the clinic, we're using two main platforms, either the Foundation One Heme platform or the MSK Impact platform. And they're, for the most part, similar, although some of the genes are a little bit different. And also, in terms of the sample types, Foundation One Heme is able to accept blood, bone marrow, as well as paraffin-embedded slides. Whereas for MSK Impact, at least for the moment, we're typically using paraffin-embedded slides only. And all the costs of these tests are either billed billed to insurance with minimal copays to the patient or covered by institutional philanthropy. So in our first case, I'm showing a case where the molecular information is really aiding the diagnosis of the patient. And this is a young lady, a 38-year-old female who had no past medical history, who initially presented with a large thyroid or neck mass, as you can see from the PET scan to the right. This was initially worked out elsewhere, and FNA was inconclusive, so she subsequently had definitive imaging, including a CT of the neck chest, that showed a 6-centimeter mass, which encased some of the veins, as well as the trachea, etc. And then in the incisional biopsy of the lymph node, which I'll show you, it really showed a diffuse large B-cell lymphoma that was arising from a follicular lymphoma. So kind of a funny little diagnosis, if I may say so. And so, with the help of Dr. Dogan, maybe we can interpret these slides, but largely this is large cells and some mitotic figures here, and strong staining for CD22. I think he needs to bail me out here.
Yeah. So morphologically, the pathologist whose report saw this was concerned that on the top panel you are seeing there's sort of a nodular architecture to it, and obviously there's a diffuse large B cell component, which you are seeing on the lower panel with that is the nerve surrounded by the infiltrate, and these are very large cells. So there's a diffuse large B cell lymphoma, but they were concerned that maybe there's a follicular component because of this more pale area that you are seeing there. Phenotypically, it looked like a typical follicular lymphoma, I guess, kind of phenotype that's CD10 negative. There was BCL2 expression. You see but however interesting, there's some CD23, which will become more important later. Yeah. And the neck location, that was a sort of the consideration here.
So based on this, at that time, we were sequencing all of our primary frontline patients with foundation. And so this report came back showing a SOX-S1 translocation, rearrangement, a CD58 mutation, as well as a frameshift mutation, as well as a CYP2TA fusion. The piccolo is commonly seen but clinically irrelevant, and a TNF-AIP3 mutation. And based on some of the data that came out of Dr. Steidel's group in Vancouver, we found that CYP2TA genomic alterations and mutations are actually commonly seen in primary mediastinal B-cell lymphoma. It can be seen in other diseases, and at least based on our own literature or our own data, we see it in marginal zone lymphoma and diffuse large B-cell lymphoma, but it's very common in this disease, and this fits well with her clinical picture. So just to sort of conclude what we ended up treating, so the data for this Foundation One Heme took a long time to result. We weren't at a time where it came back within even a week or 2 weeks where we could really make a change as to what we did. But what we did for this young woman, was incorporate radiation at the end of her treatment, because at least for primary mediastinal B-cell lymphoma, we know that radiation is a good treatment for this disease. So in our second case, I hope to present to you how we're using some of this data to enroll our patient on clinical trial. So here we have a 67-year-old gentleman who initially had follicular lymphoma when he was diagnosed in 2009. And at the time, he had localized disease that was irradiated, and subsequently, a couple years later, he had rituximab for a relapse, and also bendamustine with rituximab for 6 cycles. Eventually, his disease transformed, and this was proven via biopsy. And he got large cell-directed therapy with R-CHOP for 6 cycles. And at that time, when he relapsed in sort of late 2015, he was sequenced as well when he was biopsied, which we'll see the results of. And he was also given rice for three cycles. Because he didn't really respond to rice adequately, he was consented to a clinical trial. And when he didn't respond to that clinical trial, he was treated with gemcitabine and doxorubicin, which he had a small response, but not a complete response despite 2 cycles. So this is a heavily pretreated patient with transformed follicular lymphoma into diffuse large B-cell lymphoma. So based on his sequencing, we found that he had a CREBBP mutation, and in particular, it's an S16A deletion. And this is a mutation or deletion that affects the histone acetyltransferase domain, that we think it's an inactivating mutation that would predispose patients to sensitivity with a histone deacetylase inhibitor, such as mositinostat. And based on this information, we enrolled him on one of our clinical trials with an HDAC inhibitor that enrolls specifically for patients with CREBBP and EP300 genetic alterations. And so right now, he's 7 cycles and going. At minimum, he has stable disease, but if you look clearly at the before and after pictures, he has a remarkable shrinkage of his axillary lymphadenopathy as well as his pelvic lymphadenopathy. And he's near at least a partial response. So this is just some of the information that we're using. Does the panel want to comment? No? Okay. So lastly, we have one more case where, we don't have clinical trials for every mutation. As Dr. Intelkofer told you, there's a long tail, and a lot of them are not pathognomonic mutations. But I don't think that we should lose sight of the fact that some of these mutations are relevant to our clinical practice. And as everybody else has alluded to this morning, there are papers from Dr. Wilson's group that in his paper with patients with diffuse large B-cell lymphoma, the patients with non-GCB or ABC subtype of diffuse large B-cell lymphoma seem to be more sensitive to ibrutinib therapy. And within that is the hypothesis and some of the clinical data supporting that patients with MYD88 mutations are more sensitive to ibrutinib therapy. And in particular, patients with both MYD88 mutations and CD79B mutations. So here this is just a mutation data, but this particular patient is an elderly gentleman who really is not a transplant candidate. And he has pretty bad large cell lymphoma that initially involved the testes as well as multiple nodal sites. He progressed primary refractory through frontline therapy as well as second-line therapy. And in his mutational sequencing, we find that he has a MYD88 mutation, L265P. This got cut off a little bit, but he also has a CD79B mutation as well. So based on this, how can we frame sort of our management of this patient? And it's not coming through, but our service has over 45 active accruing clinical trials. And to narrow that is quite challenging. And so at least for him, based on this mutational profile of MYD88 and CD79B, we know that we have an actively accruing clinical trial using ibrutinib in multiple subtypes, including mantle cell lymphoma, follicular lymphoma, and diffuse large B-cell lymphoma. Sorry, that got cut off a little bit. And so he is enrolled on this clinical trial, which is essentially 2 oral agents. It's very early in the course for him, but at least within the last couple of visits, he's doing well and his symptoms are improving. So with that in mind, I want to say that genomic profiling gives us unprecedented information about lymphomas, and these findings have major diagnostic and prognostic implications. How we select the platforms, really, we have to understand them a little bit better because they have different strengths and weaknesses. And depending on the clinical question, we can select the platform that best answers our question. And I believe that genomic profiling should be considered at diagnosis and considered routine at relapse as part of the pathologic assessment of all of our patients. Thank you.
Thank you, Connie. So I think before we free, we do have time for a question or two if anyone in the audience has a question about the initial presentations. If not, we're running a little. Yeah, question, please.
I think that's one of the reasons they were suspicious that it wasn't a conventional follicular lymphoma and were pursuing genomics as a way to determine whether it might be PMBL, given the presentation.
Yeah, first case is the follicular lymphoma when it was a diffuse large B-cell lymphoma, really the consideration was there was a follicular lymphoma in the background. You mean the retroperitoneal
abdominal,
case?
okay.
That's the second case, yeah?
So I think the question is, is it unusual that there wasn't bone marrow involvement and that it was a localized abdominal mass in that setting? And I think that was one of the features. I don't know, do we have a marrow on that patient, Santa?
Yeah, it was negative.
It was negative. So we know a percent of follicular lymphoma patients will have negative bone marrow, upwards of 60% actually immunohistochemically. So I think it's within the clinical realm. Okay.
Just for Dr. Dogan, I think it'd be good for everybody in the audience how you really are differentiating MYC-positive diffuse large B-cell lymphoma and Burkitt lymphoma. How are you pathologically dealing with that? Because they both have similar genetics.
Yeah, so the morphology still is the driver. So if it looks like Burkitt lymphoma and stains, it's BCL2 negative with a strong germinal center phenotype, CD10, BCL6 expression, BCL2 negative high
So you're
proliferation.
really relying on BCL2.
Yes, BCL2 is the main. If the BCL2 positive is no-go for Burkitt lymphoma.
Right.
So many of the aggressive diffuse large B-cell lymphomas and so-called high-grade B-cell lymphomas are BCL2 positive, so that is the differentiation. Burkitt lymphoma has apoptosis. Many of these aggressive B-cell lymphomas do not have this extensive apoptosis star sky, so that is very helpful. But one thing actually I forgot to emphasize, we have a long history with the this change in Burkitt lymphoma or high-grade B-cell lymphoma definition. We have a long history using high-grade B-cell lymphoma terminology in very different clinical contexts, as well as pathological contexts. Still, you'll see in our reports high-grade definition bleeding into, for example, a standard diffuse large B-cell lymphoma without an essentially MYC classification. So WHO now is really making it into identifying these very aggressive neoplasms. So when you get a report from your pathologist saying it's high-grade B-cell lymphoma, is this the real high-grade B-cell lymphoma, if you like, or is it just you are using to identify an aggressive B-cell lymphoma? If you remember, high-grade B-cell lymphoma, early in the working formulation, identified not only these Burkitt-like lymphomas, but also some of the diffuse large B-cell lymphomas. In Kiel classification in Europe, high-grade B-cell lymphoma was used for all diffuse large B-cell lymphomas. In 1994 real classification, high-grade B-cell lymphoma was very similar to current WHO classification to identify these very high-risk cases, and that was dropped in 2001 classification. They called it atypical Burkitt lymphoma. In 2008, we made it into high-grade B-cell lymphoma, diffuse unclassifiable between B-cell lymphoma, and so there's all this terminology change. Now I think they have gone back to essentially the real classification, 1994, where high-grade B-cell lymphoma is associated with very high-risk neoplasms, but it is also used for intermediate-risk neoplasms. So you have to really be careful to differentiate those, I think, because treatment, you guys treat it differently. And this is really problematic. So it's on the part of pathologists to make sure that the high-grade B-cell lymphoma is really restricted to these very high-risk cases, not used liberally to identify more other aggressive phenotypes.
Thank you. I think we're going to conclude the morning session, and we'll probably hear more about the confounding factors of those changes in our large cell lymphoma talk. Thank you to all three of you.